Okay, so we're going to get started. Welcome, everybody, to today's Global Neurology Forum, which is the social, cultural, and emotional dynamics of dementia care. My name is Camelia Rodriguez-Sackburn, and I'm with the Global Brain Health Institute. We have those zooming in internationally, which you can see in the list on Zoom. We also have folks here in San Francisco with us. And I wanted to just have a special welcome to any of our Atlantic Fellows or Atlantic Senior Fellows for Equity and Brain Health who are joining us today. This program is made possible through a partnership between GBHI, the Global Teleneurology Service, and GBHI is a collaboration of UCSF, Trinity College Dublin, and Atlantic Philanthropies. Just a few housekeeping items before we get started. Today's session will be 90 minutes. It's going to be recorded and shared out afterwards for educational purposes. Those on Zoom will be muted until the Q&A and discussion portions of the program. And if there is any background noise, just please mute yourself. That'll help for a nice, clear discussion. And please, if you're on Zoom, feel free to share any questions. We like a lot of interaction, so feel free to just chat in your questions or ideas as we go through the program. Thank you so much, and I'd like to invite up Dr. Salvatore Spina, who's going to introduce our speakers and just do a little framing for today's program. Salvo.
Thank you, Camelia, and good morning, everyone, and thank you for being here early this morning. I just want to remind you briefly that the Global Neurology Forum is this partnership within the Department of Neurology here at UCSF aimed stimulate a discussion, a dialogue among different people with different levels of expertise among different parts of the world. So to better understand how to improve care for patients with dementia. We've had 6 programs so far. And today we are very fortunate to have as a main speaker, Dr. Nikki Mirgafori. So I'm Alyssa Bernstein, who's going to be the host of this conference. We'll interview Dr. Mirgafori. I have to say that as a clinician, one of the greatest privilege in our profession is that of walking at the side of patients and their family. I really do believe that this is one of the greatest portions of this profession. And having met Dr. Mirgafori a few years ago is a full testimony of this. So I look forward to hear about her experience and for all of us to learn how to improve our. So I'll give you to Alyssa now to start the conversation.
Thank you so much for being here today, and I'm really excited to introduce Dr. Nikki Mirgafori, who I've had the great privilege of having numerous conversations about her story. And I just want to very briefly introduce her before we go into a more detailed introduction of the story. So Dr. Mirgafori is an artificial intelligence scientist and a teacher. She brings a really interesting intersection of an understanding of science, technology, as well as spiritual practice and meditation and insight. She has directed international research programs as a principal investigator, mentored postdocs at PhD, and a scientific advisor, and she also works at Spirit Rock Meditation Center, leading, guiding lectures and workshops, and a whole host of other work that she'll weave into her story here. I think the most important thing that I want to say about Dr. Mirgafori, again, is just in hearing the story of her work as a caregiver mother, really just took caregiving on, gave a true gift to her mother with kindness and love, and I think her story will provide a lot of insight to all of us about what happens outside the walls. And as a medical psychologist, session I appreciate the experiences and lives of people who come to our clinic and what happens outside of the clinic, what the story of the caregiver is, and the clinicians. And so in the process of setting up this session, I took a logical approach really of, trying to understand Dr. Gafor's story, figure out between us what the best way is to really present that to all of you. And so we came up with the idea of sort of live interview, which is what I might one-on-one caregivers that I work with research. So really excited to be able to both introduce narrative style and also really hear wisdom. So we'll begin. I'll hold this closer to my mouth. I think we'll begin now, and I just wanted to ask Dr. Mirgafori to begin by just introducing herself and tell about who she is and what has shaped her experience and abilities as a caregiver.
Thank you so much for the kind introduction. And first, I just want to say that I'm really glad to be here. And I appreciate the invitation to be here and for this program. And to say that my intention for being here is to offer what, the story, the caregiving story, and maybe of benefit to everyone who is in the caring profession in any aspect of it. And so I'll say more about that. But so to answer your question, to say a little bit more about myself. So I think, as you mentioned, I'm an academic. I'm an ex-academic, a computer scientist. So the lens of science is how I see the world. And also a Buddhist priest and lineage holder in Buddhism. So that's another hat that I wear. The contemplative practice is the hat that I wear, that I have brought in to the way that I've been caring for my mom, and also the lens through which I see the world. And another thing to mention is that I will come out is that another aspect we'll be covering today is the social and cultural aspect. I immigrated to the U.S. when I was 16 years old. My mom was about 50 years old. So the cultural aspects of being the first generation immigrants in a country and going through something like this is something that is going to come out today. I'll pause there. And actually, I want to say a little more about the intention for me to be here. I want to go back to that. And for a moment, I actually wanted to put on my contemplative hat. And I want to invite you to listen today to the story in a different way, not in the way that you would usually listen to, a technical presentation. But actually, in fact, the first invitation I have is to become embodied. Because we're often, especially as scientists, we're in our heads and we're thinking. So what does embodiment actually mean? I'm going to invite you to try that on as you're speaking with me, and just try it on for size. Actually, first, try your posture, being more in your body. What does it feel like if you're more in your body? Just having a sense of integrity of sitting with feet on the ground, with your hands down. Just landing in your body, actually feeling your feet, feeling your hands. Can you feel your hands as you're listening to me? Is that possible? Can you feel your breath in your belly, moving the center of gravity from your head to your belly, and listening as if your whole body is an organ of hearing? How does that feel? So now I invite you to listen to this story, not leaving your seat, not leaving your body, because that also supports you not to have empathetic distress, not to get overwhelmed, but actually really be able to support and hear the story and inhabit it as if it were your own story, not somebody else's. But the invitation is, what if this was your mother and you were going through what I went through? So that's the invitation.
Thank you so much for that invitation. I think, as Dr. Spina said, figuring out what it is to walk in the shoes of a caregiver or a patient is something that clinicians try to practice. And I think what you've showed us is a way to inhabit that even more deeply. So I would like you to share just a little bit about who your mother was and, not just the disease that she experienced, but, what she meant to you, what her personality was like, and anything that you feel would be important to us to understand as you delve into the story of her disease experience, her caregiving.
Sure, and to say that I feel there will be tears as I talk about it today, and I think an aspect of vulnerability about the story is why I'm here. Otherwise, you can give a third-person report of it. So there will be tears, and hopefully there will be tissues too. But just to say about my mom, so she was an unconditionally loving person. That's how we knew her. She was the matriarch of the family in Iran. Everyone came to her to ask for help and questions. And I've often described her as a force of nature. She was a mother to many. In fact, that's what we put on her gravestone. So many people felt that she had to really support it and raise them. And she was also a very strong person. A lioness is another way. She was a business owner in Iran, even though she was dyslexic and never quite learned how to read and write. But she had multiple businesses in the U.S. She moved here when she was 50 without knowing a word of English, and still worked her way to owning a successful business. So she was a really impressive person, and again, a source of complete acceptance, unconditional love, and very, very generous to everyone. So that's the memory I have of her as a mother, as a human being.
Thank you for sharing that, and also for emphasizing the role that vulnerability plays in sharing this type of story. And I think for the clinicians in the audience, also anytime patients and families come into the office, there's an amount of vulnerability that is involved in telling the story, because even taking history from a patient or a family involves a lot of vulnerability, as I'm sure you experienced in the process of working with providers here at the Memory and Aging Center and in other healthcare settings. So anthropologists often look at illness narratives or experiences, and I think what I'm considering what we'll do here today is have Dr. Mirgafori talk about her caregiving narrative or her caregiving story. And so, I've heard the story from her, and I just wanted to ask, that as we go through, her experience, that we're going to focus on the social, cultural, and emotional dynamics that came up in the experience of caregiving. But what I've seen from her story, and that you all will as well, is how much the kind of practical dynamics of interacting with the healthcare system come into play as well. So her story is framed around personal loss, grief, and pain, and love, but also of being an advocate. And so, I invite you to listen for all of components of the story as she shares her experience, particularly in thinking about different time points in the progression of the disease, from diagnosis to dealing with care transitions and making decisions, and then ultimately figuring out how to make her mother most comfortable and feel the most safe towards the end of life. So
Thank you. So I think I want to also talk about the context, the social context, a little more before I get into the story, and that is, again, about immigrants living in diaspora. And I think the couple of aspects to really be cognizant of as I share the story is when people have immigrated, in our case, the social structure is very limited. There are no extended families, aunts, cousins that would be back in Iran. So that limited social support has had a huge impact in the way that support was able to be provided. And the other aspect is the cultural conditioning that is different. So in the cultural conditioning that I come from from the Middle East, you are supposed to take care of your parents when they get sick, when they get old, and that's the way it's done. And you're considered heartless if you have to put them, have other people take care of them. And now here, this is a very different cultural context where it's not possible, and with nuclear family, so that there's a sense of guilt. So all of that becomes a part of the narrative and the reality of one culture that is transplanted in another culture. So with that context, I think as I mentioned, those are the different aspects of what I like to talk about, and the first really to acknowledge is the grief and really the excruciating pain of losing someone you love slowly. And I think with this particular illness, with frontotemporal dementia, it's the personality changes. My mom lost her cognitive ability. She lost her ability to speak by the end completely. And only their emotional sounds that she was able to make, and basically through communicating through smiles and eye contact. Also, her physical functionality degraded over time, ability to walk, controlling body functions, and her behavior became disruptive in so many ways, and at times aggressive. So this sense of bewilderment and helplessness as a caregiver, not being able to do anything as the process unfolds. And so the sense of grief is both seeing the person that you love go through all these changes and being helpless. I mean, doing my best, but still helpless, not being able to stop the process. And also watching her suffer, watching her be sad, watching her be depressed, watching her be angry, and watching her at times not be clear what's going on, not understand what's going on, why is she getting the reaction that she's getting. And also at times where there was a sense of self-awareness for her to see her grief, realizing how she's changing through this process. And basically, it's one aspect of it is the excruciating grief of seeing the process unfold and my mother becoming my child and really becoming like a child in terms of her cognitive abilities and even less physical ability than a child. For me to be her guardian and to feel the responsibility to make all the decisions for her. So that is an aspect that is really underlying. But in the narrative, actually, I'm going to focus on the daily interactions, the daily, or rather the interactions with the medical world as a patient advocate, which in and of itself had stresses and challenges. So increasing, the excruciating pain of losing someone you love is kind of like the underlying theme, but then being a patient advocate and interacting with the medical world itself, it had lots of challenges. So I like to I've divided in our conversations into really three phases. One phase was when she was living at home, and that had two phases when we didn't know what was going on, and the other phase when she was diagnosed, so we knew what was happening. The next phase is a very challenging phase that she had to be moved, or she was moved to a nursing home for 5 months, which was the most challenging time, and I will share that. And the last phase was when she was living for about 3 or 4 years in a small care home, a 6-person assisted living, which at the very end was a hospice period. So those are the three phases. So the first phase, um, and of course each phase has had its own challenges. So when she wasn't diagnosed yet, and this phase lasted for almost a decade, and it's hard to say thank you. And it's hard to say when really the symptoms, the very early symptoms started. It was really hard to tell. But her behavior started to become different and difficult, and couldn't quite figure out why mom was behaving kind of strangely a little bit. But it was so mild that maybe she's just having a bad day. It was so unclear. And again, this went on for a decade. It's a long time. So over a decade, at times she would be more irritable. She would be more offended. So with her friends or her relationship, her employees started to deteriorate. They were more upset with her, and also her relationship with her clients started to deteriorate. She started to drive more recklessly, and again, all of these symptoms are kind of like get worse over time. At first, maybe speeding a little bit, and then just more and more recklessly. Her judgment started to decrease financially, socially, and trusting people too much. Trusting Conman, for example, wants to fix her car, and they completely messed it up, and she started to become more restless, taking long walks, sometimes late into the evening, and hard time finding her way home, getting lost and finding her way home. And again, this wasn't at the very beginning of the 10 years. Towards the end, these were some cues, some inappropriate behaviors. She couldn't read social cues, and this was again towards the very end. Especially, she couldn't read social cues. Awkward behavior, couldn't follow directions. She would talk to strangers, and as if she recognized everyone when we went to have a walk in the park. Again, towards the end of that period, knocking on neighbors' doors late, calling them, and then for wanting to walk in front of the traffic, not realizing cars were coming. Language difficulties, word finding, or switching topics in the middle of conversation without realizing. Compulsivity, and that started to happen towards the later part. She would shop bulk items and then give it all away. She was very generous, so that aspect never changed. But then the compulsivity of actually buying too much, and also started to eat too much. Another aspect of compulsivity, and also a childlike sense of trusting everyone. So imagine being the guardian of someone who's child inside, but actually an adult on the outside. So in that phase, we didn't know what was going on. It was just socially really complicated. What's happening? So she was living at home, and I think the diagnosis, as difficult as it was, frontotemporal dementia was actually quite a relief. I at least know what is going on. It's emotionally really complicated. It's not a diagnosis you want to get, at least, but there's a relief that at least you know what's going on. Even though really as scientists, we don't know much what's going on and we can't do much about it. So at that point, in that phase of her, so some of the challenges there were in terms of her getting diagnosed, the long wait time to see specialists. We saw specialists at Stanford, and we were lucky to be able to see Dr. Spina at UCSF. There's the various waits, and also I know that if we hadn't really tried, if I hadn't been patient advocate, she would have just seen a local person, and they had no idea what was going on. I was looking at the notes last night. They were pretty much clueless as to what is going on. And the other complex, so what was happening at the time, before she got diagnosed, she was living at home, and she was going to daycare from 9 a.m. to about 2 p.m. And daycare, there was a lot of um, interesting, stimulating things, for example, music or interaction with other elderly. And through that system, for example, it was very challenging through that system, which is unlocked, to actually get an external referral to see a doctor at UCSF. So it took so much patient advocacy. And had we, had we not established a relationship with UCSF and Dr. Spina, as you'll hear through the story, her care would have been very different. So again, the medical system kind of wanted us just to see someone local, someone without really and they probably wouldn't have never figured out that it was actually FTD. So during this period after she was diagnosed, then she was still going to the daycare, and now we knew what was going on, and her behavior became more and more restless, and she wanted to leave the daycare and go for long walks, and her behavior became inappropriate and disruptive. They really couldn't control her. She just wanted to get out, and it was very, very difficult for them. So we kept having these family conferences, and also to say, I have a half sister, my mom's other daughter, so she would be called in. We would be called in and have these family. And at some point, basically, I think my mom had threw coffee at a staff member she didn't like, because those were the kind of inappropriate and disruptive behaviors that she had. I mean, not beating anyone, but like didn't like someone. She felt. I think she felt disrespected. So she would often feel disrespected by people, and she would react. So basically, we got a phone call that she can't come here anymore, and immediately you need to find her another place. Within, I think, 3 days or something, we had been looking for other places because they had been telling us that her situation is getting worse and she cannot be left home alone anymore, 24 hours a day. She needs care. So, making that part of the long story short, we had to, in a short notice, basically, the daycare place found this place in San Jose, which was a nursing home, and I think the idea at first was that maybe it would be short term, and it ended up being short term, 5 months. But so I took my mom there, and the idea was, so the recommendation we got, and this is the part of the story that I truly, truly regret. So the recommendation we got was from the social worker at the daycare was it was best for her to be at a nursing home with skilled nursing staff that was locked. So my mom absolutely hated the place, and rightly so. Nursing homes or hospital-like settings. So she thought it was a sanatorium, that she was taken to a place. She was crazy, and she absolutely hated it. And she was angry because she felt abandoned. She's taken from her home and she's left at this place. She was angry, and every time I went to visit her, I remember she wanted to leave with me. She just didn't want to stay there. She wanted to go home. She wanted to go home. That's what she kept saying. She wanted to go home. And it was just heartbreaking, really, really heartbreaking at that point. And I remember her saying, well, why don't you just come and sleep here one night? You see what it's like. And that, to me, she still had a lot of clarity at that point, even though the disruptive behavior. And at that point, her disruptive behavior actually became aggressive behavior because she was angry. She was really angry. Still loving towards me and us and family and kind and really happy to see us, but really aggressive towards the staff there. Um, she would pull the nurses' hair, spit at them. Well, part of that was she was angry because her possessions kept getting stolen at this place too. It was not a well-run place, it turns out, and her wandering increased at night. She would wander and wander through the other rooms. So that period, her behavior became really, really difficult, and the resident doctor there prescribed medications to her which were contraindicated with FTD, and she received Depicone, which made her more agitated, Clonopin that increased the lesions in her brain and made the conditions worse, and Celexa that the dose was dangerously too high for people over 65. And she was almost 80. And they started they wanted to increase Seroquel to basically just completely drug her. So it was a very, very difficult time at that time, because on one hand, my mom hated being there. She was truly unhappy. She wanted to go home. She was angry. She was miserable. She would be crying. And I didn't know what to do. It wasn't safe for her to be at home, to be left alone at home. And her condo was on the 7th floor. So, and we didn't feel like if we got people to stay with her at home, that she wouldn't leave, because she was a strong, physically strong person. She wasn't safe to be at home. And she hated this place. And we were told that assisted living is not appropriate for her. And the doctor is medicating her inappropriately and into oblivion. And I was getting calls from the nurses almost daily about her behavior, that, oh, she's pulled our hair, she's done this, she's done that. She's like, so it was an excruciatingly difficult time. And so, and also during that time, I think one thing that was supportive in terms of at least her medication was working with Dr. Spina. I remember bringing my mom up to the UCSF during that time, realizing that the medication she's getting is making her worse. So trying to be a patient advocate, trying to get the resident doctor at the nursing home to change the medication. And that was yet another, because of course they didn't want to do that because she was having behavioral issues. Anyway, at some point, the nursing home decided that they couldn't have my mom there anymore, because her behavior was too disruptive, and we had 30 days to find another place for her. And what they recommended, which I really wish we had done, skipping the facility altogether, the nursing facility altogether, was a care home, assisted living care home, a small center with only 6 beds, like a home. And I think I had perhaps concerned that earlier, and that's another issue, I think, in the U.S., because these small facilities are not as, it seemed to me, not as well rated or controlled, or because they're so small and all over the place, so there's not enough information about them available to do research for someone who's a caregiver like me. So larger facilities who seem to be run by professional staff, there's more information, even though the ratio of caregivers to patients is terrible at large places. So at that point, I reached out to as many places as I could to try to do research and educate myself. And this was completely new to me, and not knowing what to do. I also reached out to UCSF Memory and Aging and asked for, how do I go about this? And they also offered name of a dealer. So there were various dealers who would show you these small 6-bed care places. And some dealers are ethical and some are not. They're just doing it to get a commission. And unfortunately, the person I got referred to from UCSF, and I think the person who referred me didn't know any better turned out to be an unethical one, who didn't do anything, and afterwards still wanted a commission, adding stress to an already very stressful situation. It just boggled my mind. But finally, again, I think I'm so persistent. So calling so many places, I finally found my way through some nonprofit organizations that gave me the name of a few places, a few care homes, small care homes that were recommended, and they were not making any money off of it. So finally, that's where she ended up. And the beginning, I think when she transitioned, when she went to the small care home, at the beginning, I think she was so antagonized and so angry still from having been at the nursing facility that when she arrived there, she had difficult behavior with the staff. She was still, her night wandering into other residents' rooms, taking her clothes off. And if they closed the door at night, she would be angry, banging at the door. And again, it was the first couple of months that were very, very difficult. And I would get almost daily calls from the owner of the place that, we can't have your mom. So I would negotiate and she would calm down for a couple of days. And again, so it was very difficult to get care for her with the situation. So finally, I got a 3-day notice that she can't stay here anymore, and need to find a new place, and wasn't quite sure what to do at that point. I felt like I was at the end of my rope. And also to say that, I would have loved to be able to take care of my mom, and I wasn't able to. I mean, I also have a chronic condition and my energy waxes and wanes. So physically, I was not able to take care of my mom. And at that point, through grace, my mom caught a cold, and by the end of the cold, all the aggressive behavior went away. So her affectionate, kind, gentle, not just with the family, she had always been kind and gentle and loving with the family, but also with the caretakers started to come up. And a very loving relationship with the caretakers, and they loved her. So, and at that time, through communication with her local PCP, and Dr. Spina tried to got her completely off Seroquel. And she got completely off Seroquel. And that also, I think, in pointing out another complication there is at some point we had to change her PCP, primary care physician. And the first primary care physician, we would have a meeting with Dr. Spina, and he would recommend, okay, reducing, and and the nurse would send a letter, and I would share it with the doctor, and he would say, okay, dose reduced. But then when we changed the primary care, the next primary care would not change the dosage, and he would say, well, if UCSF doctor wants to change the dosage, they can do that themselves. And whereas UCSF would not prescribe medication, and they would want to go through the local doctor. So there was some stressful period there, kind of trying to figure that out. Anyway, finally managed. So then there was a period of ease, I would say, for about maybe 3 years, or not ease, actually that's not the right word, a period of stability. But even with stability, there are plenty of day-to-day challenges with caretaking. It's, at that point, her language was starting to go away. So I installed a camera in her room so that I could both interact with her, and I could also see how she's being treated. Is she really being treated kindly? And in fact, I had to get one of the caretakers fired, who was really abusive towards her, and I saw it on the camera. So it was really everyday monitoring. I would call every day and ask them, how much has she eaten? What has she eaten? And she was pre-diabetic. What is her diet? Did she get enough this? Did she get not too many carbs, not too many sugars? How much did she drink? Did she have a bowel movement? It's like having a child who can't speak for herself. So caring every single day, like how is she doing, and trying to talk with her when I could. So, and through this time, she lost her ability to walk and her body functions and swallowing. And then the last phase, really, of this is the entering the hospice phase, which is the next one. And so what happened was she had a syncope when she was in the shower towards the end of this period, like 5 months before she passed. She had a syncope and went to the hospital, and the test showed that she had pneumonia, UTI, and sepsis, which were treated with antibiotics. And this was a local hospital, and again, with some visiting nurses that were trying to administer morphine to her, which would completely confuse her even more, and her recovery would be very difficult given the conditions of her brain. And so again, it was so frustrating trying to get proper care for her, and she hated being in the hospital. So after 2 weeks of being hospital, it seemed like she was a little more stable. We went home, and 2 days later, again, she wasn't feeling well. I think they hadn't administered the right antibiotics or whatever it was. Anyway, so then went to Stanford Hospital, and at that point, I think what I want to highlight is the Stanford doctors were at that point actually very hesitant. They didn't want to treat her at all, saying that, basically wanted to say, okay, this is, you need to enter hospice. This is it. They didn't want to treat her. So, and that time, I remember reaching out to Dr. Spina, having lots of conversations with him, like, what is the situation here? Is this the end? And the recommendation was that actually she can have a comeback still at this point if she is treated. Because these kinds of episodes happen once or twice towards the end, and you will know when the time is right. But it seemed like at that point the time wasn't right yet. So again, I was a patient advocate with the Stanford doctors, and but they were not quite listening to me. They would not. There was this, because it wasn't coming directly from Dr. Spina, they would not take my word for it. They would, and they were not able to connect. Dr. Spina and the Stanford team were not able to connect and have a call. So, and they were kind of miffed. The doctors seemed to be miffed, actually, that, why isn't your UCSF doctor talking to us and talking through you? So, ouch. So for me, again, that is a problem with how care is given, because, I'm pretty educated. I'm honest. Why would I lie? So anyway, making a long story short, again, at that point, finally they did provide the care. They did treat my mom with the correct antibiotics, and she did bounce back, actually. She did bounce back. And we were able to go back to the care home, which at that point actually really felt like home for her. And she bounced back for about 5 months. And at that point, we entered her into hospice care. But she was thriving, and used the mirtazapine to help her appetite and weight recovery, and because she had lost a lot of weight through being in the hospital and not eating at all. And then later discontinued the mirtazapine, and she became more wakeful. And we really had 4 wonderful months that we wouldn't have had. And she had another birthday at the time, with all the family getting together and celebrating her, which was quite a gift, really a gift. And it made us ready. It made us feel more ready. I mean, had they not treated her at the hospital, we wouldn't have that time to be ready. It would have been a very frustrating goodbye. But having had that extra 4 months in hospice, she was still at the care home, but under hospice care, was really a gift. And she was still bright, and she recognized all of us with a big smile, delighted to see us. And then the very last phase is when she had another syncope. And at that point, it was clear that, we didn't want to go to a hospital, and she was in hospice. So at that time, moved my mom to my home for the last 4 weeks of her life because she didn't want to live, she didn't want to die alone. So wanted to be around her. Um, and at that time also advocated for her to be given oral antibiotics to reduce her pain and reduce her fever, and then at some point it made sense to stop that, and she refused food, and then she passed away in my home. And she did not die alone, which is not what she wanted. So she did not die alone. I was there holding her hand. And on her deathbed, I think it was really a privilege to be able to care for her and be with her. And anyone who's been with dying people in hospice work, she had a lot of clarity. She had no words, but a lot of clarity in recognizing being with people. Very clear. A lot of love, a lot of joy, holding my hand, holding other people's hand tight. And so she was aware of what was happening. It was clear that even though there was a lot of cognitive abilities not present, but there was a lot of cognitive abilities present. And there's a complex life in there that was happening that I didn't have access to, but I knew was happening. And she was aware that she was dying. She was aware that she was giving her goodbyes. And all the friends who would come, and I remember actually some friends came and visited whom she hadn't seen for 3 or 4 years. And at that point, she wasn't speaking. And at the end, when they left, she said, "Merci," which is in Farsi is thank you. Thank you for coming to see me. So she was very clear about what was happening in her dying process and letting go with a lot of peace, a lot of peace. So her life and death was a gift. And I'm just really sorry for all the suffering that needlessly she had to go through.
Thank you so much for sharing and for your vulnerability and for taking us through. I think weaving this story of both the emotions, some of the cultural issues, and then challenges due to that, and as well as managing the healthcare system. And I think it's clear that you are an incredible advocate and have a lot of healthcare system literacy, and so it's really hard to imagine hearing the story for those who don't have as much ability to take on this advocacy role or the resources to do so, what that would look like when it's already so challenging for someone who is really capable of taking this on. And so I was jotting down some kind of themes that came up that we might discuss in the panel, though I have one more kind of important question that I do want to end with before we go there. But I think, it's really clear that there's a lot of issues around continuity of care and care transitions and, the emotions that are so wrapped up in, simultaneously grieving and trying to manage this really complex system. And I'll, ask the panelists to really talk about how we might go forward in trying to make this easier on caregivers, or what we might be able to do to support those transitions and the cross communication between providers, care homes, how to make choices, comfortable with the choices. There might always be some regrets, but how to kind of, do as much as possible to kind of relieve the burden on caregivers. But the last question I really want to ask Dr. Mirgafori before we move into the panel is a question that I asked caregivers, when I do my research interviews, I always like to end with this question. And it's about the joys of caregiving, because I think there's so much emphasis in the literature we read about caregiver burden, and in the stories we hear that are full of pain. And yet I do know, both from talking to Dr. Mergafori as well as to every caregiver that I've interacted with, that there are moments of real joy and connection and love and surprise and humor that can come out through the caregiving process, and healing and things like that. So I'd love for you to just share a little bit about some of the joys you experienced, things that might have been surprisingly wonderful about being able to care for your mother, and then we'll move into the panel.
Thank you. I think there is so much, so I will just select just a few things to share here, and that is, so I would say that actually every time I went and visited my mom, especially towards the end when her language was lost and she was only communicating with words and emotional sounds, like she would, she would be watching television, and I would come from her back and stand in front of her. She would light up and scream, and she would be so happy, and as if it were Christmas, and just seeing her and hugging her and just kissing her, that was just such a reward that she was happy. And I think there were some other happy moments. I remember taking her to see her doctor together with the care, one of the staff members at the care home, whom she was holding her hand as well as my hand. And so it made me so happy that she was so happy with the care she was receiving at the care home, that at some point she let go of my hand and she was holding this other person, this girl's hand, Jenny's hand. It just made me so happy. She felt like she was at home. This was finally at home. So, and once here's another little anecdote. I mean, at some point I wasn't, towards the end, not clear whether she recognized objects, so, which is part of FTD. So, gave her an orange, and she took the orange very carefully and started to peel the orange the way you peel a grape, like the oranges, and she peeled it, and then she put it in my mouth. So the sense of care and love, it's just, there were so many. And also the last thing I would share is, there were times that I would be sad, and maybe I would cry, and she would hold me, and she would comfort me. It's okay. Without words, she knew what was going on. So there was every interaction with her, even on her deathbed, it was just a sense of joy and peace and love. I mean, she cared for me. She was my caretaker through this process. I'll just add one last thing, and that is, one day when I was driving to her, there was an accident on the road, and I saw, and on the road there was a hand. There was a human hand on Highway 101. I was quite shaken going to my mom, seeing death, and again, her embrace, her love, her care was just, it's okay. It's so yeah, it's priceless. I mean, it's being with her and being able to care for her the best I could, to be her patient advocate, and to have the knowledge that if I wasn't there in the world, with my tenacity and best as I can level of skill of navigation, she would not have had the care she did, still with some regrets for things that could have been better.
Thank you. So now I'd like to invite Dr. Spina, Sarah Delaney, and Mark Toma up to join our panel here. I'm really excited about this particular panel because we have representation from a neurologist, a nurse who's just an amazing caretaker of caregivers and people with dementia, and then a social worker who, at the Memory and Aging Center, who's very involved in helping people access services and trying to support the process of, navigating the healthcare system. So I'll start out with a question, and then I think we'll see if anyone in the room or on Zoom has anything that they'd like to ask. I'm full of questions, so I can go on if need be. But Dr. Mirgafori and I kind of talked about what we might want to ask the panel to reflect on, and I think all of you have expertise in different areas of thinking about, hearing your story, and it's hard to hear a narrative like this. I mean, it's, I was feeling uncomfortable at places, and sad, and confused, and there are a lot of emotions that run through us when we hear someone talking so much about their deep experience here. And so now thinking about the work you all do, knowing that this story is, probably very common in a lot of ways. I mean, there are unique elements to it, but this is a common experience for people struggling with these diseases that we see at the Memory and Aging Center. So what can we do going forward? And particularly, I'm thinking about, the issues around continuity of care transitions, helping someone find support in who is from a diaspora, who is in a diaspora situation and might not have the social structures in place to really, fully encompass them in this process. So I know each of you might have a different perspective based on your particular discipline, but sort of, where do we go from here with this kind of story that we've heard today?
I'm Mark Toma, social worker here at the Memory and Aging Center. Thank you. I just want to say, first of all, thank you for sharing your story, Dr. Mirgafori. It was, you took beautiful care of your mother. So it was a real privilege to hear your story. Thank you. I was a caregiver for my father, long distance, who had Alzheimer's, and so some parts of your story I could relate to. But anyway, thank you. So yeah, I have some thoughts. This is not thought out or anything like that in terms of a plan, but in my experience, what I find with people with dementia and caregivers, and that's actually anybody with any kind of serious illness in this country, and older adults, but particularly with dementia, when there's oftentimes, in my experience, a person has cognitive impairment, but that it's not diagnosed. And so the family may not understand what's going on. Other care providers don't understand what's going on, but it's kind of left to the side. And so just that you had to fight to get a diagnosis was huge, and it shouldn't be that way. That's the first thing I would say, is that education on both the community level, but also the provider level, the payer level, has to be there in terms of the importance of the diagnosis, so that we understand what a person is going through, and then how to plan for that and how to support the caregiver. And this is actually my bigger thought, is that we have kind of a in the United States anyway, caregivers, mostly family, or anybody who's around, is expected to give care to somebody, usually family members, when they're sick, or in this case have a cognitive impairment. But we don't have the infrastructure to put that in. It's very fragmented, very spotty in terms of support for caregivers out there. And I mean, like, community to community. We're fortunate in San Francisco to have some programs here that support caregivers, and many of them are not that old, but it's piecemeal. Things like respite, transportation, meal support, day programs, access to a social worker or a case manager who really understands the system and can help navigate somebody through that. It's very piecemeal, and caregivers are left trying to navigate this on their own. And if you are fortunate to connect with somebody who really understands the system, that's great, but most people don't, in my experience. And so my question I often ask myself was, well, where's the common good in our country? Where is our commitment to each other as a community, in kind of an ethical way, and not just causing no harm, but actually promoting the common good for each other? And what I'm seeing is that there's a kind of a funneling of wealth upwards instead of across the population. And this, of course, is a huge question, but I guess my frustration and what I would hope is that we'll move into a place where we're caring more about each other, and that it's actually shown in social services, that there are supports there from when someone is born until when they die, and that caregivers are not kind of left out there trying to figure it out on their own. And I think as a society, we have to come together to do that. And just one more comment. This is when you were talking about your experience with your mother's experience with the care home. I had the real pleasure of working with our Huntington's disease team, and when one of our patients goes to a home, we really try to talk to the administrator, the director, the caregivers, so that they can understand Huntington's disease and understand how to best care for that person, and then be available for them. And we're just, it always, I have to say, it makes a big difference. And I wish you'd had that, because I think that would have helped with your mother.
I'll answer the same question from Amber. So I think a couple of things that I'm trying to make myself as loud as possible that seem to come from, that I heard from your story, were that, well, you emphasize that it's a slow, decline, and then there's really challenging behavior symptoms that really nobody really knows what to do about in this setting. And then all the transitions you face seem to have sort of a crisis aspect to them. Like you have 3 days, you have 30 days, which is so stressful. And I think trying to make the right decision or figure out what decision to make so much harder. So I think the way our healthcare system kind of works is not to support this sort of long decline. Like even hospice, or you go to the hospital, people want things that are fast and quick, and medications are fast and quick, and kind of figuring out how to support this long decline over time, and it takes time to think through the decisions and what really are the options, what is the best option. And it sounds like that, except for when you took the time to do the research and kind of figure out everything yourself, that wasn't something you could do with support. And so that was one thing that I heard. And then I just had a couple of practical questions in terms of, I feel like I absorb the wisdom from people and what they figure out, especially people who are good advocates, and try to share it with the people I work with. So this idea of having cameras in the home, I've heard from other caregivers, and it's sort of controversial in general, although in the cases where I've heard caregivers using it, it's been really useful. So I'd love to hear more about that and how that was sort of negotiated perhaps with the staff. And then moving your mom home for the last 3 weeks and figuring out how to provide 24/7 care when someone has a high level of care needs. I'm curious how you manage that.
Thank you. I'll answer the second one first. And that is with the last 4 weeks of her life. My mom's sister also moved in, so the two of us were taking shifts, and I basically stopped working and canceled everything on my calendar, all meetings, everything, and I was just completely available. And friends and relatives brought supplies and food, and that's how we managed it. And there were nurses from hospice that visited, I think, twice a week to help support. But it was a Hail Mary effort the last 4 weeks. The other question about the camera. So the staff, at first there was a Skype camera in her room, and it would be turned on, and I would have interactions with her, and then speak with her, and then later the Skype camera stopped working for various technological reasons. And actually, then I had basically what's it called, a security camera, so which could be checked from my iPhone at any time to see what's going on in her room. And the staff was fine with it because it was in her room. They knew it was there. It was nothing hidden. It became a problem when the care home was changing ownership. They wanted to sell, and the next owner and there were some issue. Oh yeah, the next owner didn't want to have it in there because I think the oh that's it. Yes, there was quite an issue with a gosh, what's it called? The person comes in and checks on licensing. There was an issue with licensing. So licensing basically was saying that you cannot have a camera in the room because of privacy of the care staff. There was no roommate. My mom had a private room, and the camera was just pointed to her room, to her bed. So I wanted to make sure that at night she's covered. She would usually push her covers away, so I would call them, can you go cover her, all that. But so yeah, so there was a problem with so the licensing wanted me to take the camera away. So again, there was advocacy of describing why my mom had restless leg syndrome. So finally wrote a letter that because she had restless leg syndrome, and I would observe at night whether she had issues that night, and I would call the staff to go and put lidocaine on her legs. So that was the reason why I finally wrote the letter, and I didn't hear back from them. But they wanted the camera removed, which is, to me, like, anyway, I'll just let that sigh be the answer.
Yeah, first of all, I want to thank you again for being here, for sharing your thoughts with us. Yeah, the comment that I want to make is probably more on the transition of care. So, it is an extremely important part of our job, and it's one of the most difficult things to do, actually, for clinicians. Very often, making a diagnosis is not that complex. In the routine of management of care is somewhat what we learn, but the transition of care is actually not something that as clinicians we are strongly prepared. I think that now relies on many factors, and some of them are also cultural and environmental. So in my experience, for instance, before my American experience as an Italian, the Italian system relies a lot on family care physician. So the primary care physician is always center of care, is always the person who makes that final decision together with the family or the patients on what to do when specialists move more in a surrounding territory. They provide suggestions, but they're not there all the time. So I think in the United States, I don't know if this is the experience that's shared by other clinicians, but that networks of protection in the territory, in the environment of one person that is somewhat like the commander-in-chief of the situation. Personally, also, you can just talk to directly. So if I had to make the call, who am I going to call? That is something that I miss as a clinician. On the other hand, instead, in this country, in this city, in this institution, there's an extraordinary support of other figures in terms of other expertise, so from social workers, nurses. That makes our life incredibly easier. But it's definitely an area that for which we have to work. And first, we need to know what the problem is, and then definitely work a lot more to improve it.
To say something, given my experience here and the difference between the Italian model and how in the U.S. that there's not centralized. And I think with my experience, given that the primary care often is not informed, does not have enough information about FTD. It's such a peculiar, not well understood illness that in order for me to get the information I needed, you had to be my lifeline support and reach out to you at times of transition about, okay, what to do, what can what to expect, should we go this way or that way. And And that information, unfortunately, the specialized information, if was available at the primary care, but that can't be. So I'm not quite sure how that can work. I mean, this way, I think in some ways it worked well, and I'm very grateful for the communication that we had, you and I, in the way that you supported me and my mom. But I don't know how that could be done through the PCP.
So I'd like to open up for questions, either from anyone in the room or I think you could let me know if anyone on Zoom has a question for Dr. Mirgafori or anyone else on the panel. Yes.
Yeah, I just wanted to thank you for sharing, and that I've been doing pretty much the same route with FTD with my mother, about the same period of time, and also all the same difficulty. My mother is in the Netherlands, which is pretty similar to the Italian situation, that you do a lot of primary care, and the primary care, even in the Netherlands, which is excellent care, doesn't know anything. So the process to get her where she is now was really hard. But then it's fabulous care, because you can learn a lot from once you get to the system, but that took like 14 years. I just wanted to ask a question about what you were saying about thinking that your mom was like a child. And I recently had a conversation with Dr. Ann Basting, who corrected me on that when I said that she really adamantly thinks that that's not the case. And so I wanted to know more about you. And then I had a discussion about being a mother myself. It actually helped looking at her that way, but that she's not a child, right? And so I was grappling with that, and I wanted to know your thoughts in retrospect, if you still think that your mother was like a child, or maybe your ideas about that relationship for you, the caregiver, and your mother, and how that relationship has changed over time. How do you look at that now? And does that still apply? Do you still feel that, or is it maybe more complicated?
So I appreciate the reflection, and also I would be curious as to why the person you were talking to vehemently felt that it's the person, the child, is not appropriate. I would be curious to maybe speak with you offline afterwards. But I think as I reflect on my experience, it really felt like, you know, there were some childlike qualities that my mom started to have. I mean, that there's a sense of simplicity, that the child is loving, trusting of the world, and it doesn't make good decisions, doesn't quite have very well developed decision making, but and also towards the later stages, you know, if you think of a younger child, really a baby that's born, doesn't quite have control of their bodily functions, needs to be lifted to be moved, which was the case for my mom. Towards the end, she needed two-person support to be moved, and then she couldn't be moved at all. So I think there's some childlike qualities, and the simplicity of the, you know, not being able to have a deep conversation or any more kind of simplistic conversations, which, for example, you'll have with a child. So, or in terms of language development, the child doesn't have a lot of words anymore, even though they understand what's going on. So that was towards the end. My mom understood what was going on, but she didn't have the words. So those are all the qualities to my mind that still, for me, make it, in a way, and then the sense of responsibility that I have for this person who cannot take care of themselves. They can't make decisions anymore. They can't speak. That, to me, is the most heartfelt way. It was childlike. I had become the mother. And I'm happy to talk with you offline afterwards.
Anyone else in regards to
I've heard that before. I think I'm curious if it has to do with, you know, kind of negating the life the person has lived. And I hear caregivers sometimes, like when you went to the hospital and they were saying, "Why are you treating her?" That I've heard other caregivers have similar experiences, and it seems like, you know, people look at her and see this person who's not talking and not taking care of themselves, and why would you treat them, and not seeing them as the person who you see them as. So I guess if it's, I guess for me it's a matter of context. If you're treating them as a child or someone whose life is not of value, then that would not be respectful. And if it seems like it's a way of helping you, you know, love and care for someone and feel a sense of responsibility and take that on in a loving and way, then that can be useful, I think. So it depends on the context.
Can I just add that I find pediatrics a really interesting kind of thought experiment for how to involve the caregiver, you know, the parent in the care of the patient. So in pediatrics, it's expected that the parent is their health and well-being part of the discussion. You know, if the mother's having a problem, the doctor can, you know, address that issue because they're responsible for the child. And yet in dementia care, you know, there are a lot of problems because the caregiver is separate and not connected that way, according to the healthcare system. So I think, you know, I understand problematic aspects of talking about a patient as a child, but I also see that there's a lot of possibility and learning that we can gain from looking at, you know, actually a pediatric setting and what the responsibilities are involved in caring for someone who really can't advocate for themselves.
Right. Just to repeat what you were saying, since it wasn't broadcast, what you were saying was you're still grappling with this idea of child versus, you know, whether this is an appropriate way to refer, because what the dementia specialist was bringing in was that this person still has wealth of memories they've had of life. So I think a lot of it has to do, and I also appreciate what you brought in, which is really has to do with the, you know, the frame semantics. Like, how are we using the child? If we're using the child as, oh, just a child, kind of demeaning, just a child, or child, precious child. This is a precious child. You know, if I'm at the hospital, this is a precious child to me, even though it doesn't speak or can't express themselves, but this person is precious, or it's just a child. So it has to do a lot with the frame semantics of the word.
Any other questions coming up on Zoom or in the room? Okay. Anyone on this? Any other questions on the Zoom side of things? So I'll return to the room. Go ahead.
So my first question is, I know you mentioned your mom was 50 and migrated to the U.S. and didn't know English. So I'm curious if there were language barriers when you were looking for care homes or when she was in the nursing home. And my second question is about hospice. So I know from a cultural perspective that can be a difficult decision to make. And I've heard from a lot of South Asian families and Asian families in general, it's hard for the family to reach a consensus on hospice. And
they kind of view it as giving up on care. And in my family alone, people choose ventilators and feeding tubes instead of considering hospice. So I'm just curious to see how your experience with that was and if that was difficult.
Thank you. So I'll answer the second one first. It's fresh in my memory. So the decision for hospice, it actually seemed, I understand culturally the differences, but I think having been in the U.S. now for so many years, over 35 years or so, and also being educated about what hospice is and what hospice isn't. Actually, it wasn't, I mean, I made the decision. I was the primary decision maker. It seemed like the most compassionate way to have the ending. I did not want my mom to die in the hospital. She didn't want to die in the hospital. And hospice can be such a loving way for the person to have an honored departure. It's instead of intubated and so ouch. So that seemed, so there was a time that hospice actually, it made sense, and it wasn't a decision I made alone. Again, I'm grateful to have had the support of Dr. Spin. Like, yeah, it makes sense at this point, and still hospice will give you care, and you know, she had great care for another 5 months. But yeah, so I hope that answers your question. And then the other question regarding the language barrier. So my mom, she did learn English. She became fluent in English actually, and she was trilingual, Turkish, Azeri, Turkish, Farsi, and English. And then so finding care homes, I think she was still communicating in English at the time. She was still able to speak. But then after she was in the care home for some time, she couldn't speak in English. She would speak in Azeri Turkish, which I barely understood, her first language, and then came back to Farsi, and then only a few words of English. She could still understand, but she couldn't communicate. And she would only speak in Farsi the more she deteriorated. So there were language barriers, but I think by that time there was enough rapport established between the care home staff that it didn't matter. There was a warmth of feeling between all of them.
Yeah, no, actually I have a question. Is that okay? When your mother was at the adult day health program and they said they could no longer care for her because of her behaviors, I'm just curious, from your perspective, do you think if that program had adapted to her behaviors, she would have been able to participate longer? Or did it feel more like, well, this is kind of a one-size-fits-all model we have? I'm curious what your thought is about that. Well, I'm curious, like, did you feel like they were asking her to leave too soon, that she really could have been cared for better there if they had just adapted their daily schedule model?
Thanks so much for that question. Absolutely, that's how I felt, because at the time, you know, she was still quite functional in so many ways, and her behavior was not aggressive. I mean, throwing coffee at someone, of course, is not, but it's not life-threatening, right? It's not the end of the world. It was too soon. It was far too soon. Yeah.
In my experience, and I'm not going to, well, I'm going to talk for Sarah, but probably we see that a lot, where people have to fit into a particular model of care, and if they don't, then you have to find another place for them, another setting. And usually it's not a really complicated fix in our experience.
Like a coffee cup with a lid or something.
So I want to be sensitive to time, and unfortunately, I think we have to wrap up. But I just wanted to thank Dr. Mirgafori so much for sharing her story with us, and really taking an approach to letting us all sort of empathize and be in it with her. And then also to all of you here who do so much of the amazing care work at the Memory and Aging Center. You know, I know that the MAC provides a wraparound of level of support that is really unique and, you know, hopefully a model that can ultimately, you know, extended elsewhere because each of you has such an amazing wealth and ability to manage some of the challenges. And guess if anyone has any questions, we can talk after the session closes. But thanks for being here and for organizing, Camelia and Dr. Speak.